So as Kathleen stated, I am fortunate to be able to work on Optimistic, which has given me a real glimpse into some of the complications of and the joys of working in the nursing home world and trying to do research there to improve healthcare there. Today I want to talk about a grant that's in the early phases that I was lucky to be awarded from IU Health, the Nurse Intervention to Facilitate Transitions to Home Environment, or the Nifty grant. And I'll just say, like, even before I was an Optimistic, I came with this skill of being able to make these acronyms for studies. So it's the first skill you need. So I have no disclosures. We find a lot of times when we're doing nursing home work that we need to help orient people just because a lot of folks aren't as familiar with nursing homes. So I'm just going to spend a few slides letting everyone know what the milieu is that we're working in. So there's about 15,000 nursing homes in the United States. About 20% of hospitalized Medicare beneficiaries end up being discharged to a sniff. So what's a sniff? A skilled nursing facility. This is a place where your loved one may go if they're just a little bit too weak or too debilitated to go straight home from the hospital when they've had an acute illness. And so they'll make a stop at a skilled nursing facility or SNF. They'll get a little bit of rehabilitation, and then the plan and the desire of most people who end up in SNFs is to eventually go back home. A percentage of those patients do end up having to stay in the nursing home, and those would be then long stay nursing home patients, and that's the focus of Optimistic. So just to distinguish those two projects. So there was a study a few years ago that looked at the likelihood that folks are going to end up getting some sort of nursing home care. And basically they found that of all Americans who make it to 65 years old, so those of us who are fortunate enough to make it there, there's about a 46% chance. So about half of us who make it to 65 are going to spend some time in a nursing home, whether it's as a long stay resident or as someone who's receiving some of this rehabilitative care. So basically this is going to touch, if it doesn't touch us, it's going to touch someone we know or we love. And this is a visual that I have shown this audience before, but for me it's simple, but it sort of helps to show the movement and the different areas or even silos of care that people experience when they're going to nursing homes. So I don't know if you can, yeah, you can see the mouse, right? So, you know, someone's happily living at home, they have an acute illness, like maybe a pneumonia, maybe they're older and they're a little bit weaker, and so they can't go straight home from the hospital, so they end up going to the skilled nursing facility, but their goal, again, is to get back home. So if we look at people who end up going to these SNFs, these skilled nursing facilities, they tend to have higher mortality rates than those who end up going straight home. They tend to have higher hospital readmission rates also. By their very nature, they usually have more comorbidities, more medications. A lot of them do have dementia and so forth. There was a study that was done in the Carolinas that found that about 20% of them are going to seek acute care after they're discharged from the SNF within the first 30 days, and 33% are going to seek some sort of acute care within 90 days. So they're very high risk for staying in this cycle of care, of going into the hospital and back out again. So we did a study when I first came here as a fellow, using some enhanced Indiana data, and we were able to look at some of these associations. You know, what is it about this SNF group that may actually help to prevent some of those adverse outcomes, right? And we found actually that of the patients who went home and then were readmitted, the ones who were not readmitted had a much lower chance of readmission if they had a home health visit. So someone actually came into their home, not them going in to see the doctor. There was, I'm sad to say, being a physician myself, there was no significance to going to see your PCP within a week of being discharged from the SNF. But if you had someone come in your home and help you figure out how to reintegrate yourself into the home environment, then you had a much lower chance of getting readmitted to the hospital. So then, with the support of Regenstrief, I was able to do another study, a qualitative study, the FACT study, where we looked at patient experiences. We actually interviewed patients who went home from the sniff to find out more about their experience and more about their needs. We did a grounded theory analysis, and we found 4 main themes. The comforts of home were really important, information needs, post-sniff care, and then independence was a major theme. And I presented on this, I think the last time I presented a WIP, I talked more about those results. I'm going to go a little bit more into those because that informed then the Nifty study. So within those themes, we found that something that was really important was the duration that people were away from home. It makes perfect sense, but I just hadn't thought of it until I heard people say it over and over again in interviews. They were gone from their home for a minimum of 2 weeks, and some of them up to 3 months. So you can imagine how hard it would be to then go home and sort of reassume your own medical care, independence, and things like that if you haven't even been physically in your home managing your medications and things like that yourself for possibly more than 2 or 3 months. A lot of them really focused on food. Social isolation was a big issue, especially for those who didn't have caregivers, and then just sort of physical comforts at home. In information needs, it was interesting. They would pull out these piles of paper, but then say they weren't quite sure what they were supposed to do with them and what the paper contained. So they felt this overload, but at the same time didn't really know the plan for their discharge and plan to effectively reintegrate themselves back into life at home. For the post-sniff care, a lot of them talked about the follow-up care that they had, and it became pretty clear that something that those of us who are geriatricians know, that these patients have multiple comorbidities. They are complex because they would mention 3, 4 appointments that they had to follow up on, their cardiologist, their neurologist, their primary care doctor, plus they had home health coming in. So these are very complicated patients. Medication management was a fun issue to explore. And then they also talked about therapy gains and setbacks. Some of them, really worked hard to be able to walk again, to be able to get up the steps that they needed to get up to get back into that home that they missed so much. And then they would get home and wouldn't get therapy for several days and would start to get stiff and feel like they were losing those gains that they had made in the nursing home. And then independence was a difficult issue for a lot of them. They both had this increasing independence, which was how they were able to get back home, but at the same time, they still needed assistance, and that's something that they struggled with. And anyone who's been ill in this room and had to rely on someone else for anything, any sort of care, knows how hard it is to rely on somebody else and at the same time sort of realize your limits and what you can and cannot do. So I just wanted to go back to this I'm sorry, not this slide. I will go back to it in a second. The post-sniff care and medication management, I have another slide that must have rearranged the order. So as we were evaluating this, we found that there's really a distribution of caregiving effort that people deal with as they are trying to get themselves reintegrated into life back at home. So you have the professional caregiver, you have the patient, and then you have sort of the non-paid family, neighbor, friend, niece who's been coerced into helping, or you may have nobody. And we found that with this pie chart, the pieces of the pie would be bigger and smaller for different people as they were trying to get themselves back home. And things like the ability to actually just know how to take care of themselves at home would influence how big each of the pieces of the pie were, the compensation resources. So sometimes, Medicare dollars would run out, even though someone may need help at home, may need someone to help them set up their medications. If they used all those Medicare dollars on their nursing home stay, they may not be able to do much at home with that. And then, of course, this independence really dictated how much someone was going to rely on someone else to rely on themselves. And then we found that during that transitional period, that period when people are sort of that liminal time when they're reintegrating themselves into life at home, that the arrows would sort of show where these would shift as they were reintegrating themselves. So we built this conceptual model to try and look at how it is we might have some effects on some of these issues. And this is drawn again from our grounded theory analysis. And And then also we added the pie chart to sort of represent the push and the pull of the independence and everything else that the patient was experiencing. And then you can see we added this nurse facilitator intervention here at the bottom, which is what the IU Health Values Grant is, and where I'm really trying to make an impact on these people so that they have the positive outcomes from this transition home and not the negative outcomes that might be associated with this. So the values grant, the Nifty study, is aimed at improving this sniff to home care transition. It's a 3-year grant. Our goal is to recruit 20 to 25 subjects for the intervention and then look at 20 to 25 usual care subjects. This first aim is what I'm in the middle of right now. So I've hired a nurse who has been doing nursing longer than I've been alive and who has worked a lot with us over in geriatrics at Eskenazi to help me refine and formalize the protocols for this and materials that we're going to use. So she and I are in the middle of that and are starting to write the IRB and hope to get that submitted within the next month and a half to get that approved. Then we're actually going to start the intervention, and we want to, again, this is a feasibility, right? So we want to examine the feasibility and acceptability of the nurse facilitator intervention with patients and their caregivers. We're hoping that at least 80% of the enrolled participants, I mean, I'm hoping 100%, but okay, fine, I'll say 80% because I'll be realistic, will have this intervention delivered successfully to them. And then we're hoping that these key stakeholders will find this intervention acceptable. And then, of course, we want to analyze our results. So some of the principles of the intervention are that we want to bridge these silos of care, like I was showing in that earlier image. We want to make sure that there's an in-person nurse visit. Some studies use telephone visits a lot, but I really think that for this highly vulnerable population, an in-person visit is important. We want it to be a very timely intervention. I've set the lofty goal of that the nurse is there within 30 hours of discharge from the facility. We want to make sure medication reconciliation is done during that in-person visit, because that is a huge issue, as we found in the previous FACT study. I found at least one study that found there's about 100%, possibly 100% medication error rate when you transition from the skilled nursing facility to home, just because a lot of these patients are so complicated. And then we also want to focus on the handover of physical therapy to try and maintain this independence and function level when they go home. So this is the slide I was speaking about earlier. This is just a reminder from the FACT study of how complicated medication reconciliation can be. When I presented the FACT study before, I pointed out that, this person who has this very neatly packed medication package was in fact not taking their medications correctly because they were using the medicines from prior to their acute illness, whereas this person who does not look organized seemed to actually be doing things the right way. So we have to really, this is in a way, it's a individualized medicine at its best, right? People just really have their very set systems for how they're going to do things, and you've got to find the right one to make sure things are done correctly for each individual. So some of the groundwork and intervention that we're working on. So we are, working on developing the materials. I just wanted to sort of show the overall plan for how this is going to play out. Basically, developing this groundwork, the nurse facilitator will gather all the information about a particular patient once we identify somebody for the intervention, visit the person in their home, prepare a PCP information form. This is intended to be a one-page summary of what's been going on. We don't need a huge medical record or anything like that. We just want the important information to be distilled and available to the PCP. I practice primary care myself at Eskenazi and at the VA, and I don't know what your all's experience is, but I have yet to see a discharge summary from another physician about someone's stay in a nursing home. So I think that's really important. And then the nurse facilitator will also do a phone call a few days later after the visit just to make sure any loose ends are tied up. And then our research staff will gather some additional data for the study. So things that we thought were important for the nurse facilitator to gather are, contact information for the patient, the discharge medication list, therapy recommendations, and so forth. So the idea is that the nurse is going to be talking directly with the therapist in the facility to make sure that they know exactly what it is that they can and should be doing at home. And then confirming some of the discharge follow-up, including home health care, which we thought was so important, primary care and also specialist care. In the home visit, then the nurse facilitator will do a full medication reconciliation, and we'll also remind the patient of the therapy limits and goals. A lot of times therapists, part of the packet that patients get when they leave the sniff is actually, a packet of exercises you can do at home and things like that. But if they're not even looking at it, it's not really helpful to them. So the idea is that the nurse this will be a verbal, in-person, face-to-face reminder of what they can and cannot do. And then things that we think the nurse should communicate to the primary care would include things, of course, like a summary of the hospital and sniff course, medication changes that have happened, and then this drives me crazy as a geriatrician. When patients go to a nursing home, it's basically like getting a free geriatric assessment of your patient. You get a score of their cognition, their mood, you get a lot of information about their function, and all of that gets submitted to CMS and nobody ever sees it. As a PCP, I would love to see this information, and so I really think that this needs to be also broadcast to the PCP so they know if there's some sort of cognition issue. Is this something they should actually follow up on later? And then the phone call, again, we'll just review what was already looked at, just to make sure there's no loose ends that need to be tied up. The research staff then will follow up with the patient and administer some of the instruments that I have listed here to look at things like readiness for transition, functional ability, a symptom score, which has been tied to readmission risk, and we'll also do some chart review at 1 and 6 months. And then this is actually my final, second to last slide. I get asked a lot, how is this different from other care transitions interventions? And so I finally just put it into a table. I see my primary mentor smiling at me back here because I will say she asked me to do this like a month ago and I finally did it a week ago. But anyway, so the care transitions intervention is something that Eric Coleman, he's probably one of the most famous people who has done transitions of care work. So that is his primary intervention. That's in the first light gray column. GRACE is a program that many of you may be familiar with. It was studied and founded here. And a lot of our patients at Eskenazi still receive care and at the VA actually still receive care from the GRACE system. And then Nifty, that's us, that's me. So that is what we're going to be doing. So if you look at it, the type of contact that the patients have is actually, they all thought that in-person was important. And I think that's true. I agree with that. For both the care transitions intervention and GRACE, it's a nurse practitioner, whereas I think that a BSN nurse, a baccalaureate trained nurse, is okay for the Nifty intervention. Now, I will say that I'm part of the team, right? Like I will be reviewing these patients with the nurse. So there is a prescriber sort of in the background looking over everything. The recruitment site is different for all of these, hospital versus primary care, although I know GRACE also recruits from the hospital. But if you go back and read the literature when they were first published, primary care is where they are, ideally are recruiting their patients, and then we're recruiting from the skilled nursing facility. The target patients for all of these are older adults. But undergoing different types of transitions, right? So GRACE, again, is looking in for community dwelling patients from primary care. The care transitions intervention is in the hospital, and then we're looking at patients who are actually definitely in the sniff. And then the interventions are definitely a little bit different too. So Eric Coleman's intervention, his ideal is that this whole huge personal health record is made for the patient, and the patient uses that. There's a transitions coach, and they do a lot of coaching and so forth. I think that for mine, I really want it to be almost like a surgical intervention. I just want the nurse to be there. We're a bridge, we're smoothing the transition, and then the PCP takes over again. For Grace, they do an in-home, very extensive geriatric assessment, which again, I think is very useful, but it's for a different population. And the duration of the intervention, I think, further emphasizes my surgical approach. So, the care transitions intervention is at average of 24 days. Grace, according to the publications, an average of 2 years. And then for ours, 2 weeks is the maximum we would be involved in the patient's care. So, like I said, this really is a work in progress. I'm early in this 3-year grant, and so I wanted to get feedback if anyone has anything. I too only left 5 minutes, but please feel free to ask questions or point out errors in thought on my part, anything like that. I'm tough, I can take it, and I'd rather have it, be a good intervention before we really launch. So if anyone has anything to say, go for it. Yeah.
So I wanted to kind of talk a little bit about the, kind of the differences between Nifty and CTI. So I think, one of the things that that Coleman emphasizes is that the reason that it's centered around the personal health record is so that you're really coaching the patient so they can deal with these transitions on their own. So my question to you is, how do you feel your intervention will really prepare if you're doing a surgical intervention? So you're getting in there, you're staying for 2 weeks, and then you're pulling out, and then this nurse interventionist is doing a lot of the work on behalf of the patient. How do you think the patients will do once the intervention is over and they go back to regular life? Because I heard you say that from your sort of qualitative work that one of the major things is that once they get discharged and they get sent home, they're kind of overwhelmed and they need, they don't know what to do with the medication transition. They don't know what to do with that. What happens the next time they go, if these are really kind of high-risk people, that they go back into the system and then come back home? Are they going to get this intervention every single time? Or are you going to have the opportunity? I think one of the things that Coleman talks about is that during that first time they get the CTI, they're then sort of mentally prepared for the next time they have a transition in care. And so if you could address that, that'd be great.
Yeah, sure. No, thanks for the comment. So, I will say one thing is the idea is to prevent re-entering that cycle of care. But as we all know, there are unavoidable hospitalizations. So that's a really good critique and a good point. I think the idea behind the Nifty is that really these are silos of care in a lot of ways. And so the idea is just to be a bridge to help them get back to primary care. Primary care is where, and any sort of specialist care that they're receiving in the community, that is where the care is supposed to be happening and helping them to get through that. The problem is what happens when they're in these silos, they exit and it's like a bleak landscape, or that was how it was described to us in the qualitative study. There was this, I'm not sure what to do. I've got this pile of papers, that's 80 pages. I don't know which page to turn to figure out X. And so the idea was really that this person would be providing the bridge, but not necessarily sort of taking over. I think when Eric Coleman was developing the CTI, we didn't have as many electronic medical records and things like that. And so, now we have that. We have an Epic, people are able to access a lot of their own information. And so I don't want to try to replace what's there. I want them to be able to just get reintegrated back into what's already in existence. Does that make sense?
It does, although the PHR is designed for the patient, not for the providers in the healthcare system. So even though you have access to Epic, the patient does not. And so
I've looked at my own labs and other
things. They're not going to see their records from the sniff.
Oh, I see. You're
And they're
talking
not,
about this skilled
yeah, and
nursing
they don't get all their,
facility.
and their medications are not listed in Epic, right?
I
It's got
see.
their it's got their lab results, and it might have access to some notes, but it's not going to have their meds, right? They don't have, so I think that the idea of the PHR, even though it's a paper-based thing that Coleman came up with, the idea is to get the patient to think about their medications and how they're going to self-manage their medications. So it's a tool, it's a cognitive tool to help them kind of think through that process rather than be a new kind of portal for them to go to.
Yeah, we're actually designing, so we have the one pager for the PCP, but then we have a medication list for the patient that's very simplified and based on other like true, tested medication lists for the patients. But part of the problem is that the sniff often will have a different medical record from the patient's PCP. And so again, we're just providing this paper record that a patient can look at. And again, not like 80 pages, but here is your 1-page list of your medications that the patient, can look at and know what they're supposed to take like tomorrow, basically. It's difficult with nursing homes because some of them are starting to be integrated with EHRs and some are not. So like in IU Geriatrics, we actually do put all of that we document in both Cerner and Epic when we see patients in the nursing homes. And so we list the medications and so forth, but the med lists aren't always updated because the orders that we would normally put, like if I was seeing a patient in clinic in Epic, I just put in an order for a medication. When I'm in the nursing home seeing a patient, you don't touch that because if you put an order in, then it actually sends the prescription. And when you're in the nursing home, you have to like handwrite the order for the medication. So part of it is because these nursing homes still aren't fully integrated with EHRs everywhere. And they're not, I don't know, maybe Kathleen has a different perspective, but I don't know that they're gonna be. It's very expensive. Go ahead.
Well, hopefully that is something that will happen better in the future. But I think this point of building in empowering the patient is a good point and something to think about, that not only are you helping the person in that moment, but you're also giving them some tools to take a little more ownership. It's a very vulnerable population, but especially for those who don't have the caregivers, I think it's a nice point to think about what teaching is the nurse going to be doing, like what be around, there's certainly the medications, but how else can they be kind of coached and taught?
Yeah, thanks. I'm sorry, I didn't mean to, I think you have a really good point. So yeah. I just want to definitely acknowledge that. Yeah. Well, I think we're at the end of our time anyway, but if anyone has any other thoughts, I would be more than happy to take anything else from anyone. Thank you.